fluoro, you want to look at the lesion through an imaging that is intravascular ultrasound.
Can I use a pointer? Can I use? Yeah. You can. I can.
Before they start, how many of you are using intravascular ultrasound in helping you to do? How many of the hands I can see? So quite a good number of them. And all those who are not using it, is it that they don't have the facilities? How many of them don't have the facilities and not using it? So I think most of you are not using it just because it's not available. And those who are not using it, are you convinced that you should use it? How many of you are convinced? So I think very little task for you.
Thank you, Chairman. Thank you for being here. My title is Basics of IVUS Guide Reentry in Integrated Approach. There are two ways of IVUS usage for CTO PCI. First, IVUS can detect the CTO entry, crossing the wire to the side branch. IVUS caster is inserted along this wire. After that, the operator should one more wire towards the CTO entry. Next, if first wire got lost through lumen, like this, IVUS caster is advanced along this wire. Seeing the wrong entry point, the operator should handle next wire towards the CTO, through lumen inside the CTO regions. What can IVUS do for us in CTO PCI? In my daily practice, I favor the IVUS caster of which the profile is small and of which the distance from chip to transducer is short. So in Japan, Navifocus WR by Terumo is the best IVUS. However, I know that this IVUS is launched in Japan only. So there are two IVUS, Boston IVUS and the Eagle Eye by Volcano. However, Boston IVUS has a long distance from chip to transducer. So Eagle Eye is better for CTO PCI. First, IVUS can visualize a occluded vessel. In the left panel, show that CTO entry is ambiguous. Oh, sorry. IVUS cannot move. In the right panel, IVUS clearly shows the occluded vessel from 4 o'clock. One important thing for detecting the CTO entry, to take an angiography with the transducer of IVUS at the just CTO entry like this. Thereby, we can integrate the IVUS information in fluoroscopy. Next, IVUS clarifies the guide wire position on which the IVUS caster is mounted. IVUS plotted here. This is upper entry in the subintimal space. After distillation, the operator should handle next wire. At 2 o'clock, we can see the hierarchical structure. This is another wire. I should handle this wire toward the true lumen at the 12 o'clock, counterclockwise. I will show you two representative cases. This is a mid-RC CTO case with ambiguous CTO entry. I must pull back from the sinusoidal branch. So at this point, I must reveal the occluded vessel here. So I decide to penetrate here. So I tried to penetrate at this position, however, failed because there's a steeper angle in this point. So I shifted to retrograde approach. So fortunately, I negotiated this channel. I advanced retrograde wire like this, however, wrong vessel course. I do have retrograde guide wire advanced wrong course. So I had to go back to the antegrade approach. Next step, I tried the balloon screening technique. Balloon screening technique is that dilation at the just distal of CTO entry point like this to avoid wire prolapse. Fortunately, I succeed to penetrate here. I advance this wire. Finally, I cross this wire to the distal. Antegrade success. I got this satisfied result in the right panel. Next case here. This is a mid-LED CTO case with ambiguous CTO entry. And we can see the collateral from RCA. However, LED distal is very tiny. First, I checked the IBUS to detect the CTO entry. Confirming the CTO entry, I tried to penetrate here with Gaia next. After penetrating, I checked one more IBUS. You can see the guide wire from 4 o'clock inside the vessel. After that, I advanced this wire into the CTO region. However, from collateral angiography, this wire was pseudo lumen. So I switched to the IBUS guide reentry. This is IBUS finding from distal to proximal. Left upper side is proximal, right side lower is distal. So proximal site, IBUS is intimal. However, distal site is apparently inside the pseudo lumen subintimal space. IBUS probe is a green circle, true lumen is a red circle. So rewiring point is here. In the angiogram, I confirmed this point as a rewiring point. If you use a short monorail IBUS caster like a Terumo or Boston, you can see the separation IBUS caster and guide wire. in this patient, we can see the first guide wire at the left side and the IVUS guide wire, IVUS probe is the right side. In the IVUS findings, guide wire is 7 o'clock, like this. So epicranial view is from 4 o'clock maybe. And trauma is here. So in the fluoroscopy, maybe there may be trauma is here. There may be trauma here. So I handle the next wire at this point, like this. Second wire is slightly left side. So after rewiring, I was finding it here. Green circle is IVUS probe, and second wire is a yellow point. Yellow point is apparently inside the true lumen. After that, I advance this guide wire to distal. After that, I implant a stent. This is the final result. Acute result, in the acute result, I see the main dissection, but 2 months later, I got the successful results. In conclusion, IVUS can complement information missing on angiography and contribute to more successful and safer CT of PCI. Thank you for your attention.
Thank you very much. That was very instructive and illustrative. This very delicate procedure, which is, I think, the highest level of CTO PCI. Usually the wire to penetrate will be a Confianza, a Conquest Pro 12?
Yeah, I totally agree with you. So as a second wire, penetration force is very important. So guide third or Confianza Pro 12.
But, and you showed this nice delineation where will be the true lumen, but this only works with the mechanical probe where you have the second guide wire on the IVUS.
Yes.
With the Volcano, you need to find other orientations. What do you do with the Volcano?
Volcano is a long monorail type, so we cannot see the separation guide wire and IVUS probe. So it's a difficult situation, sorry.
With your IVUS probe, right at the point where you have the main vessel takeoff, do you find there is some kind of a crowding and your wire movement gets affected? Well, some people like to just find out as to where is the main vessel takeoff, look at it, pull back the IVUS, work around that area, and then slip the IVUS again. Which one do you find is easier?
Sorry,
keeping the IVUS crystal there at the bifurcation, or?
I'm sorry, I can't follow
Do you have to remove the IVUS sometimes because it's blocking
yes. So sometimes, once I confirm the point by IVUS, removing IVUS, after that, I tried penetrate. After that, confirm the IVUS finding.
Yeah, because in your first case, your IVUS catheter was not there. In the second case, it was there.
Okay, thank you very much. So we